this next question is about rules and regulations, and we have two really outstanding experts in Scott Bruder in the U.S. and Chris Joe in Korea who live and breathe regulatory science, and this is a critical piece of obviously of what we do in developing new therapies and judging new therapies and providing therapies safely and effectively to patients. And the FTC, of course, has oversight over truth in advertising and have the power to call out groups that are making false claims or claims that are unsupported by science in their advertising and educational materials. The FDA, of course, has the charge of enforcing the idea that if therapies are offered to patients, they have safety first, and they have evidence of efficacy second. So there are, I guess, two ways I would frame these questions around these issues. Is one, what are the big mistakes that clinicians are currently committing in terms of their compliance with the Federal Trade Commission and FDA, and then second, what would we like to see in terms of regulatory decision making that would help move the world forward for clinicians and researchers who want to contribute in this area. And why don't I start with you, Scott Bruder, and then we'll go to Chris next.
Yeah, I'll try and tackle this in a couple of small bites. The things that clinicians need to understand is, first, the rules that FDA puts out, for the most part, are used to guide sponsor companies, their behavior, their development of products, their promotion and marketing. For example, on June 3rd, the FDA put out a consumer alert describing the fact that so many different kinds of products are not legally available. Things like micronized amniotic particles, things like amniotic fluid, things like stem cells, and a small other list. That is a list of products that have no legal basis for commercialization at present in the United States. What that means is, as clinicians, don't buy anything that doesn't have either an FDA clearance, an FDA approval, or ideally a letter that says that the product as a human cell and tissue product is successfully exempt by Section 361. Okay. What that also means is that for any product that is legally available, such as devices to prepare adipose tissue, microfragmented adipose tissue, bone marrow aspirate concentrate, PRP, those devices, even though they do not have a specific claim or indication for the treatment of osteoarthritis, for the treatment of lateral epicondylitis or anything else, you as a clinician may choose to use that product in your practice according to the art of medicine and your decisions based on reviewing the literature, your own clinical experience, or that of your colleagues. So the FDA does not have any sway over you as a clinician because you decide to put PRP or BMAC into a joint. They can't sanction you for doing that. Okay. Now, where the FTC comes in from a clarity standpoint is you should not advertise on your website that you are doing stem cell therapy, that you should not advertise that you're even treating patients for specific pathologies with these therapies that don't have specific language for clearance or use or indication. So I tell people to say things like, as you said, we use tissue therapies for management of musculoskeletal disorders. We have biologic solutions to musculoskeletal disorders. That also means don't put patient testimonials on your website, because that is a patient testimonial is equivalent in the eyes of the FTC and the FDA as a clinical outcome claim. So even though Mr. Jones may have been able to now ride his bike 50 miles after his BMAC injection, but he couldn't before, if he says that on your testimonial website, that becomes a claim. And the problem there is that then the FTC comes after you for false advertising. The other thing that's worse is when the FTC comes after you for making claims about stem cell therapies. And we have seen almost 400 letters from the FDA come out, warning letters or untitled letters, even at individual clinicians. And I've been at meetings and talked to clinicians who get these letters saying, it has come to our attention that you, Dr. Jones, are making statements on your website that you're doing cell therapies and this, that, and the other thing. And that has led the FTC to issue multi-million-dollar judgments against doctors. So my advice for people, I'll wrap up here, is my advice for people is if you're going to use these products in an off-label way, to ensure that you do proper consenting, that you do that you document that you have informed consent, and you are very clearly indicating to the patient that this is outside the bounds of the specific clearance or approval for that device, for example, to prepare PRP, adipose tissue, or BMAC. The only other thing that is allowable, which I've said before, is the use of these 351 culture expanded cell therapies is in the context of an IND investigation study. Then you can do those more sophisticated, complicated studies, but you can't treat patients. You can't treat patients that are outside the confines of the study. For example, we know of amniotic fluid-based studies. So you have amniotic fluid at your clinic, you're taking care of patients in the study. That's all well and good. You can't take care of anybody else that's not in the study.
Thank you. That's a good summary. You've educated us a lot in this area, Scott. It's been very helpful for clinicians in this rapidly evolving and ever-changing landscape. So
Scott, that was excellent, and you addressed the first half of the question that I asked, and I won't press you too hard on the second half, but do think about, none of us are in the position to preach to the FDA. The FDA has a huge job. It's a complicated world. I don't begrudge them any of the decisions or the structures that exist, but that doesn't keep us from thinking about, well, how could the world evolve in a way that would be better for patients and for clinicians in this space? And do you have any quick ideas about the areas in which you'd like to see the FDA either gather more information or consider modifications in the existing structure?
Yeah, you're lighting a bomb right at my feet because I deal with our colleagues and I regard them as colleagues at the agency. One of the challenges that I have seen, and I think they would recognize, is that sometimes when we're representing a sponsor and we're having a conversation about a proposed therapy, is that they don't always have the right people in the room. They don't have a sufficient number of orthopedic surgeons. In a recent meeting, they don't understand that the knee joint is one compartment. I've spent significant time trying to explain it's not three separate compartments. They also, as smart as they are, and they are very smart, they often ask questions that we all want the answers to about mechanisms of action. But I would say that and I know there are people from FDA watching here. I know that because I see their names. Is let's try to separate the distinction between the academic and intellectual interest in understanding the mechanism of action to the nth degree for some of these therapies, and let's focus on safety first, efficacy with agreed upon endpoints as really the sine qua non of what's going to be required for approval. I don't really care that the 17th downstream intracellular cascade that necessarily occurs in a broad range of patients in every study. So, we have to understand the basics, but we also have to know where to draw the line.
I think it's really important. I think both professionally and personally to see the FDA and the FTC as our advocates. They're inevitably, the world is complicated, it keeps changing fast, and all of us know this in our clinical practice. We all know it in our scientific world, and the FDA, frankly, has a bigger job than any one of us to keep track of. And so thinking about the opportunities that there is for dialogue and for education and to remediate any challenges, where conflicts don't exist. Obviously, we all have to recognize our conflicts, but opening ourselves up for a conversation with the FDA as our collective advocate, I think is extraordinarily important. Sometimes the the discussions are considered adversarial because the feeling is somehow the regulations are in the way, but they're there for a reason, and they can be changed for a reason. We just have to have the dialogue to define what those reasons are.
So George, if I could just put a bookend on that by first of all saying thank you, and saying that indeed, I may not be reflective of every person in my position who likes to help companies. We take an approach that FDA is our colleague, and we want to try to manage that way. And that means one way to help this whole process is to avoid the frivolous submissions, because these submissions have some statutory obligation by the agency to undergo review. And if they're reviewing frivolous submissions or submissions that are so argumentative, then that doesn't help the rest of us that I'll call the good guys, the guys that are tuning in, the guys that are hosting this, that want to see things done the right way. So elevating that level of education for both sponsors, clinicians, and our friends at the agency is a great goal to achieve.
So Chris, I'll open this up to you, as you have a different perspective on regulation and an entirely different environment. But I'm sure that Korea and the FDA, those regulatory agencies talk, and you live in yet another environment in the UK. What are your thoughts on this discussion that Scott provided?
The most important difference between the states, between the US and Korea, is that who pays the money. In the US, the insurance company and patients pays money. In Korea, the government pays money. So that thing makes complexity in the US. So it's a little more clear in the Korea, because all the money is from the government. So it's just illegal and can't get money from any treatment that is not allowed. And only a few things, just few things are allowed for biologics and for musculoskeletal disease. That is that PRP is just allowed last year for just one indication, for a lateral epicondylitis. And the other BMAC is approved for a very limited indication. So except that two things, and one stem cell drugs, and except the three things there, only research is allowed in Korea. So the complex is gone with this payment responsibility. So another thing is just like I said just before, in Korea, a new law was enforced last fall 2020, an act for safety and support for advanced regenerative medicine and advanced biopharmaceuticals. So it's quite similar to RMED in this US, that enables physicians and hospitals to treat and study with unapproved biologics and cells. But it's originally that the hospital can get money from this treatment with approval, but it's a little bit changed during the law making, so it's not allowed to get money from the patients. It's another way to another limitation. So it's all just research. So and in addition, while the act was for supporting regenerative medicine and biologics, but if you get into the law, it requires more data and documents that application for more than the application of IND for SIT. So this is current situation in Korea is very complicated and still very hard to move on. But I think we are on the way from all or nothing to this kind of prudent vigilance. This is the situation in Korea right now.
Interesting that you're describing that somehow the fact that so much of the healthcare in Korea is paid for by the government, that you're saying that seems to align the payer and the regulatory environment more closely, of almost strategizing together to enable regulation that may help both improve quality but reduce costs at the same time. Iain, how does that play out in the UK, where again, probably 85% of healthcare dollars are spent by the National Health Service?
Yeah, I suppose it's difficult to compare when I've never really been at the front end of it in other countries, but I think that Scott's summary was really nice there and emphasized the point that I've heard him mention in the past, is how much of a team effort it is, and we should all more and more over here, we are realizing how important it is to communicate between, don't see it as them and us, and see that we're all ultimately working towards trying to get safe treatments to our patients. So keeping dialogue is certainly keeping dialogue channels open, communicating regularly, seeing regulators and as colleagues certainly seems to be the key theme.
I think we should really stress that as you finish up this point here, George, that exactly that seeing the regulators, they're our colleagues. Exactly. This is not an adversarial relationship. That's ridiculous and short-sighted. We need to work together. I think the FDA and other regulatory bodies have our patients' best interests at heart, right? So given that, why shouldn't we be consider them our colleagues, because we share that goal for our patients. So, and you made the important point, Iain, about communication. We need collaborative efforts, open communication. Thanks Scott Bruder for all his efforts and over the years working with the FDA and kind of representing us, if you will. And Scott, you've been a great advocate for orthopedics and educating us, but also having a foot on both sides. So it's been an ongoing resource for us. So we appreciate that.